Hello and welcome to MK's Medical Review Series. My name is Dr. Mosesjrk. This is a series where we look at medical topics in great detail. Today we're going to be looking at placenta previa. If you haven't yet subscribed to the channel, please hit the subscribe button. Also hit the bell notification icon to be receiving notifications every time I post such videos. Drop a like, drop a comment if these videos are helping you for the YouTube algorithm. Grab your piece of paper and let's go. So whenever you're talking about placenta previa, remember that the word placenta previa is actually a Latin word that's going to be derived and it's going to be meaning in front of. So when you're talking of placenta previa, it's pretty much the placenta is in front of the presenting part of the fetus, of course. So placenta previa is where the placenta is just pretty much going to be covering or even encroaching on the cervical ostium or the cervical os, which I'll refer to the ostium as the cervical os. And recall that placenta previa actually accounts for a third of the cases of antepartum hemorrhage, APH. And we define APH as vaginal bleeding or at least bleeding into the genital tract that is occurring after the age of viability, which is at a benchmark of 24 weeks to delivery of the baby. And this is obviously going to be including the first as well as the second stages of labor. And remember that this bleeding can happen spontaneously or it may be provoked. And the bleeding is of maternal origin. It's not fetal. So the compromise with placenta previa is that it is affecting the mother more than it's affecting the fetus. And the incidence of this condition is about 1 in 200 pregnancies. So it is actually quite common. And you actually have to know it for the sake of your exam and for the sake of your practice. Before we actually go on further with the topic, I want to give you a little bit about some relevant anatomy about the lower uterine segment, because this will make it very important for you to understand that whenever you catch what we're going to be referring to as a low-lying placenta at a certain week of pregnancy, like for example, if you were to find the placenta roughly maybe at week 16 or maybe week 18, somewhere there, almost encroaching on the cervical ostium, you wouldn't call that as a placenta previa. You just simply refer to it as a low-lying placenta, because we'll talk of something that's known as placental migration, because the lower uterine segment usually forms during the course of pregnancy. So remember that the lower uterine segment is pretty much the part that used to be the isthmus before pregnancy, and it's going to begin to form roughly at around 12 weeks. And the isthmus, which is about 0.5 centimeters, is actually going to start to expand gradually and is going to result in the lower uterine segment. And at term, it actually reaches a length of about 5 to 10 centimeters in length. And the thing you really need to know about this lower uterine segment is that it does not contract. It stretches out. And when the uterus is contracting, remember that the outflow tract, the cervix is supposed to dilate and to increase the space so that the child could pass from the uterine cavity through the cervix into the vagina and eventually outside the body of the mother. Now, for this to happen, the muscle, the fibers or the arrangement of the lower segment of the uterus is supposed to dilate. Now, how the blood vessels are in the uterus is that they occur in between crisscrossing muscle fibers of the uterus. And as the uterus is contracting, it actually clamps down on the blood vessels and actually prevents blood flow. But then you think of this, if the placenta is in the lower segment and instead of the fibers that are surrounding these blood vessels clamping down when they contract, they'll be stretching out and the blood vessel will have more space. So the person will keep bleeding. That's why it's very, very important to note this anatomy, because of the way the uterus stops its bleeding. When it contracts, the muscle fibers surrounding the blood vessels are pretty much going to also be clamped on, and this is going to stop the bleeding. And of course, this is going to underlie loose folds of peritoneum that are going to reflect on the bladder. And when the bladder is full, you can actually see it anteriorly. And this lower uterine segment is within 8 centimeters of the internal cervical ostium at term. So this is just a little bit about the relevant anatomy that you really need to know about the lower uterine segment. Now, some risk factors of placenta previa include a prior history of placenta previa, whatever may have been predisposing you to the developing placenta previa, could be present in this pregnancy. And if you've had it before, there is generally a risk factor of you having it again. Multiparity, multiple gestations. You could understand with multiple gestations because with twins, you may get a large placenta that may be covering a larger area of the uterus. You may also have an age that's greater than 35. With most of these obstetric conditions, the older you get, then you're at risk of developing most of these obstetric conditions. Then, of course, if someone has a history of a previous cesarean section or any scar on the uterus, that may be due to a myomectomy or a hysterotomy. Because if there's a scar, then most likely that the implantation may happen at a different location. Then also placenta size, that ties in with the multiple gestations as well. You can sometimes also have abnormalities of the placenta. Like, for example, if you have a subcenturiate or an accessory lobe, then if you have this accessory lobe, it makes it easy for it to attach to a place very, very close to the cervical ostium. Then, in addition to this, you may also have some uterine structural anomalies that may be there that may predispose or may be a risk factor towards developing placenta previa. You also have certain conditions or certain instances where a woman goes for assisted conception. You may have smoking. And remember, with smoking, you're going to be having this level of carbon monoxide in your blood. Remember that carbon monoxide binds to hemoglobin to form this irreversible compound, which is known as carboxyhemoglobin, and this greatly reduces the oxygen carrying capacity of the red blood cells. Then if this reduces the oxygen carrying capacity of the red blood cells, this is going to lead to hypoxemia, and this is going to be compensated for in the uterine or during the changes of pregnancy as a placental hypertrophy. So the size of the placenta is going to increase. So most likely it's going to be encroaching on the lower uterine segment. You may also have patients that have previous curettages and abortions. You may have patients with fetal anomalies. Now, in the etiopathogenesis of the condition, what actually causes placenta previa is not really known. But there are some suggested theories that have been put and postulated. I shall mention some of the suggested theories that are there. You could read into a lot of this detail if you have the time. So there is something that's known as the dropping down theory. So remember that before a woman decides to get pregnant, one follicle, one ovum is supposed to develop in the ovary, and eventually at around day 14 of her cycle, it's supposed to be released into the fallopian tube. So once it's released into the fallopian tube, then if sexual intercourse happens during that same window period, then it's going to be fertilized. And once this egg is fertilized, it's going to be moving along the fallopian tube, and eventually it's supposed to reach the uterine cavity. At the same time, the uterine cavity is supposed to undergo certain changes to prepare itself for implantation. And then once this happens, then the egg is implanted, and of course that's how the pregnancy is going to go on from this. So now in this drop-down theory, you have this fertilized ovum that's going to be dropping and goes and implants in the lower segment. This may be due to maybe a poor decidual reaction that is happening in the upper segment of the uterus, or a failure of the zona pellucida to disappear in time around the fertilized egg. Because remember that you only need one sperm to fertilize one ovum. So whenever a sperm enters, the ovum kind of like makes this shield, quote unquote, which you're going to be calling the zona pellucida, which is supposed to disappear before implantation happens. So if this doesn't disappear in time, then it might end up disappearing when the egg has actually, the fertilized egg or the fertilized ovum has actually reached the lower segment. And this theory, the drop-down theory, actually explains a type of placenta previa, which is known as a central type of placenta previa. Then you may sometimes have persistent activity in the decidual capsularis and development of capsular placenta, which comes in contact with the decidual vera of the lower segment. So these actually explain the lesser degrees or the minor degrees of placenta previa, those where you have a placenta that's almost just touching the lower segment, because maybe the activity has been continuous from the upper segment to the lower segment. Then you could also have a big surface area, for example, with twins, same thing with smoking. And sometimes it could just be a defective decidual reaction. And so the placenta may even penetrate much deeper than it's supposed to be. It may penetrate and actually reach the basal layer of the endometrium and the myometrium, just attaching to the myometrial layer. You refer to that as placenta accreta. or it could invade into the myometrium. You refer to that as increta, or it could even penetrate through the myometrium and actually go into the serosa. So you refer to that as placenta percreta. And remember that whenever you see this on cesarean section, it's one indication that may cause the woman to go into a hysterectomy. So remember that as this placenta is going to be growing and its growth is going to be slowing down in the later months, the lower segment is progressively going to dilate. And remember, I told you that as this begins to dilate as the pregnancy goes towards term, then the inelastic placenta is going to be sheared off of the wall of the lower segment. And this opens up the utero-placental vessels and causes an episode of bleeding. And like I told you, I don't know if I could draw something for you on the screen right now. So let me just show you a blackboard. Go to a screen. Okay, a blackboard. And let me get some white ink. So let's say you have a blood vessel here. And this blood vessel here is found within the uterus wall. Then you have some muscle fibers that are going to be surrounding this blood vessel. Let's say these are muscle fibers over there. These are muscle fibers over there. These are muscle fibers over there. So we can agree that these muscle fibers are pretty much crisscrossing on the blood vessel, which is in the center here. So this is a blood vessel. So this crisscrossing muscle fibers that are surrounding this blood vessel, whenever the uterus now contracts in the upper segment, it's supposed to clamp down on this blood vessel and reduce the bleeding. But remember that this is happening now in the lower segment of the uterus and it's being stretched out. So this is not going to be happening and the blood vessels are not going to be squeezed on and the bleeding will still carry on. And further on, part of the placenta has been detached from its wall because of the stretching out that happens in the lower segment. So this is obviously going to be causing a spontaneous type of bleeding. And the bleeding can actually be worsened by trauma. So things like vaginal examinations, things like coitus, which is sexual intercourse, things like external version, or even during rupture of membranes, you may lead to bleeding. Now, in the pathology of the condition, the placenta is going to appear large and thin whenever the child is delivered. It will have this tongue-shaped extension from the main placental tissue. Sometimes you may have extensive areas of degeneration with infarction and calcification. Sometimes you may have the placenta that is actually morbidly adherent to the uterus. Those three conditions that I told you about, placenta accreta, placenta percreta, and placenta increta. If you want to remember what's for what, there's a mnemonic. So just remember, accreta attaches, so it means it's going to be attaching to the myometrium. Increta invades, so it's going to be invading into the myometrium. And percreta penetrates, so it's going to be penetrating right through the myometrium. Then when you look at the umbilical cord, so the umbilical cord may be actually attached to the margin, or it could be attached to actually the membranes. If it's attached to the margin, you call that as a battledore type of umbilical cord, or it could be a filamentous type of umbilical cord. And of course, insertion of the cord may be actually close to the external os, such that you may also have these fetal vessels that are actually passing across the internal os. And this is very, very common with the filamentous insertion, what we refer to as vasa previa. Now, what is going to allude you to vasa previa is that whenever this woman you rupture the membranes either artificially or they rupture spontaneously, there's going to be bleeding that's going to be happening when the membranes rupture, because this bleeding is due to the injury of those blood vessels that are running across the internal ostium. Then when we look at the lower uterine segment, there's going to be low vascularity of the lower uterine segment, such that this lower uterine segment, including the cervix, are going to become soft and much more friable. Now, how do we classify placenta previa? So we classify it in two main ways, okay? So I want you to know this first classification because that's what they'll ask you on your exam. But for clinical purposes, this classification has been merged with each other to make it a whole lot easier. So let's say you have your 4 grades, grade 1, grade 2, grade 3, grade 4, or class 1, class 2, class 3, or class 4. So grade 1 is what we refer to as a low-lying placenta. So I'll show you some images just shortly. So this is where you have the major part of the placenta pretty much in the upper segment in the normal position. And the lower edges are actually reaching into the lower segment, but they do not reach the ostium. Okay, so they are encroaching in the lower segment, but they do not reach the ostium as of yet. Then grade 2, you have what is known as a marginal placenta previa. So you have the placenta edge actually reaching, but not crossing the internal ostium. So you can think of it as it's just touching the internal ostium, but it hasn't yet crossed over the internal ostium. Then in grade 3, you have this partial placenta previa or partial central placenta previa. So this is where you have part of the placenta actually covering the internal os. So it covers the ostium. Whenever it's closed, it may actually cover the ostium, but then when the lower segment is actually fully dilated and the cervix is fully dilated, it may not completely cover the internal ostium. So you refer to that as a grade 3. Then grade 4 is what is referred to as a complete previa or a placenta previa totalis or a central type of placenta previa. This is where it's going to be covering the internal os completely. Even when it's dilated fully, it's going to be covered completely. Now, for purposes of clinicals or when you're working, it's easier to actually classify them as mild as well as major. So mild, you have grade 1 and grade 2. Then major, you have grade 3 and grade 4. Now, the major types, which is grade 2, grade 3, and grade 4, could be divided into two variants, an anterior as well as posterior. Because remember that the placenta could be found either anteriorly or posteriorly. So when you're looking at 2 anterior, you consider that as a mild or a minor degree. Then if you have a 2 posterior, it's referred to as a major. The reason why the posterior is a major problem because it reduces the anterior posterior diameter, and so this is actually one indication that you should take the patient for cesarean section and you should avoid actually delivering the child vaginally. So here's the picture. Sorry for the quality if you cannot see this very well. So you have here as your grade 1 a low-lying placenta. As we can see, the lower edge of the placenta is actually encroaching into the lower segment of the uterus, but it's just within 2 centimeters of the os, but it doesn't cover the os. So it's within 2 centimeters. So you have a range of 2 centimeters from the internal os, but it doesn't touch the os, it doesn't cover the os. Then the marginal type of placenta previa, that's grade 2. So this is just touching the cervical ostium and it doesn't cover the ostium. It doesn't cross over the ostium. Then a partial placenta previa, which is grade 3, it covers it partially, but when this dilates, it doesn't actually cover it completely. Then, of course, placenta previa totalis covers the entire ostium in its totality. Here's another picture to depict the same thing. So here is a normal placenta, which is away from the lower segment. It's in the upper segment. And this is a low-lying placenta covering part within 2 centimeters. Then this is a placenta previa, a partial placenta previa, which is covering part of the internal cervical ostium, and the placenta previa totalis, which is covering the entire internal cervical ostium. I think this was a repetition of the same image. So, like I already told you, placenta previa type 2 posterior is actually quite dangerous. Why is it dangerous? Is because with this type of placenta previa, you're more likely to actually compress the placenta. You're more likely to deny this child of oxygen if they are delivered vaginally. So the child may actually go into fetal anoxia. There may even be death. There's also an increased chance of the cord compressing or the cord prolapsing, which may also lead to fetal anoxia and death. So here's a picture of a placenta previa type 2 posterior. As you can see, this anterior posterior diameter has been greatly reduced. And so if the child decides to pass through this birth canal, it is very hard to do. So what are some of the clinical features that are associated with placenta previa? So some clinical features that are associated with placenta previa, you may get a sudden onset of bleeding, which is obviously going to be painless. So this is one of the hallmarks. If there's pain, then you should suspect that probably there is labor, or you should suspect that this isn't placenta previa, but placenta abruption, which we shall compare very shortly. So there is pain, and the bleeding that's there is bright red blood, because this is fresh blood. It's coming from the mother, and most of the times it's not even related to any activity. Recall that with placenta abruption, you may get a mother that has been involved with trauma, you may get a mother that has hypertension, but in this case, there may not be any related activity that may be there. This woman may have been fine and just gone to bed very well and then woken up the next day in a pool of blood. And this is actually quite frightening for the patient when they wake up and they're covered in blood all over. So if there's pain, please suspect that there may be some labor. And most of the times the bleeding tends to occur before 38 weeks. So it tends to occur before term. And like I already told you, the bleeding is maternal in origin. And in a third of the cases that are present, you may get this warning hemorrhage, what I like to call the calm before the storm. So you may get sometimes some brisk bleeding that may be there, or it may even be some spotting that you may see in the first, sometimes even the second trimester, and it may subside, but then it will recur later on in pregnancy, which is why women should always attend antenatal care, because we're going to be picking these things up easily on ultrasound scans, and we can actually plan for them and prevent any fetal or maternal mortality. So in cases, it may sometimes be asymptomatic, and you may actually discover it just on ultrasound, and in a very few cases, you may discover it when you're performing a cesarean section. Then when you examine this woman, you want to do a general examination, so you may get the general condition of the patient is probably ill. They may have anemia that will be proportional to the visible blood loss, or they may actually be in shock, they may not be in shock. Obviously, if there's anemia in the mix, this usually tends to confuse the picture of shock and everything that may be there. So you may get a patient that looks sicker than they are because they cannot tolerate just minimal blood losses. Then when you perform an abdominal examination, you want to look at the size of the uterus, and it's going to be corresponding to the gestational age. That's your symphysiofundal height. You're also going to be, when you're examining, the uterus will be relaxed, it will be soft, as compared to placenta abruption, where the uterus will actually be contracted. It may be woody hard. Then sometimes it may actually be elastic without any localized area of tenderness. And if there's tenderness, please suspect that they could be either this woman is going into labor, or there could be a placenta abruption that has occurred. Then, of course, there may be an abnormal lie, so the fetus may be in breech position or a transverse position or any other unstable lie in between. This is largely because there's a placenta that's actually preventing it from rotating and actually engaging and actually being in the correct position or the correct lie. Sometimes there may be a high presenting part. And you may sometimes palpate multiple fetal poles in terms of multiple gestation or twin pregnancies. Please auscultate for a fetal heart. If you pick up the fetal heart, confirm it with a Doppler sonicat or sonicat, which is that thing on the wards that makes a lot of noise. Then you can also confirm this with an ultrasound. Then sometimes you may not get the fetal heart, especially if exsanguation of the fetus is happening. Exsanguation is just simply draining the fetus of all the blood that is there. And then there's a sign that you may elicit, though I wouldn't really emphasize much on you eliciting this, especially when you are reviewing your patients as a student. So generally, if you were to press down on the head of the child, or press down its head into the pelvis and then let go, as you're monitoring the heart rate, you would realize that as you press down on the head into the pelvis, the heart rate usually tends to slow down. And then as you let go, it tends to recover. So you refer to that as Stanleyworth's sign. So this is obviously suggestive of a low-lying placenta, especially in the posterior type. But what you really need to note about this sign is that it's not really reliable, nor is it significant to placenta previa. So it's not a pathognomic thing, because sometimes even just usual head compression may give you the same results in an otherwise normal pregnancy. You want to perform a valvular inspection. Please do not whatsoever do a vaginal examination. Do not stick your fingers inside, because if you stick your fingers inside, then this may actually provoke further bleeding, and this should only actually be done in theater where you have actually equipment ready, what we're going to be referring to as a double setup. So you may do this in theater when you are prepared to actually carry out a cesarean section if need be. So only just examine the vulva to see if there's any bleeding that is continuous or if it has stopped. So when you do this, please take note of the color and the amount of blood that has been lost, roughly. So any woman that comes in complaining of APH, you want to say that it is placenta previa until you prove otherwise. So before you actually get a scan and actually confirm that this is placenta previa, do not perform a vaginal examination because you may worsen the situation. Then in the diagnosis, of course, history and physical examination. So like I said, when a woman is presenting with APH, pelvic examination should be avoided until placenta previa is excluded. So you may perform some investigations such as a transabdominal ultrasound, which has roughly about 98% accuracy at diagnosing it after 30 weeks gestation, but a much better resolution could be actually gotten from a transvaginal ultrasound. Then you ask me, if you're sticking a probe now down there, wouldn't it also worsen the bleeding? Well, these people are actually trained to do this. So ideally, if it's done right, it shouldn't worsen. But currently in our setting, most of the ultrasounds that we do are transabdominal. Then, of course, if you were to do a transvaginal ultrasound, that actually gives you a much superior view of the uterus. Then you may also want to do a full blood count to check for any coagulopathies that may be underlying, like a low platelet count or even an anemia that may be there. You want to perform a cross match for this patient, and you want to do a coagulation profile. So here's an ultrasound image of a placenta previa. This is what it looks like. Then I alluded to this much earlier on when I talked about the lower uterine segment. So remember that if you do an ultrasound at 17 weeks of gestation, in 10% of the cases, you may see that the placenta is covering the internal os. But then if you repeat the same ultrasound roughly at around 37 weeks, you may see that actually in over 90% of the cases, the placenta actually isn't present in the lower segment. So it's kind of like the placenta has moved. Now, the reason why this happens is because the lower segment usually tends to expand. Remember, it's going to be expanding from 0.5 centimeters at about 20 weeks to about 5 centimeters or even up to 10 centimeters at term. And this actually resolves the placenta previa. So it's like the placenta has actually moved away. And the reason why this can be explained is because there's a progressive lengthening of the lower uterine segment. And so the placenta edge actually relocates away from the cervical os. So you initially have a low-lying placenta, but later on when you repeat the scans, it may actually resolve. So that's why we don't want to tag these women as having a placenta previa. Then, of course, you may also have what is known as a tropism, which is pretty much growth of this trophoblastic tissue towards the fundus, because that's where you have most of the blood vessels going there, supplying all the nutrients that are needed for the pregnancy. Then the differential diagnosis for placenta previa are other causes of APH, which is pretty much abruptio placenta. Of course, there will be pain. We will distinguish the two conditions very shortly, I think, in the next slide. Then you may have vasoprevia. You may have some local cervical causes such as polyps, carcinomas, and these can be differentiated by speculum after you have confirmed with your ultrasound. Then sometimes you may have a circumvallate placenta. So here you may have bleeding, which is slight, and the diagnosis is usually only made after you examine the placenta, and that's after delivery. So here's a distinction between placenta previa and abruption. I'll just read them to you because the image doesn't look so clear. So we have clinical features. So in placenta previa, the bleeding is painless. And usually there's no underlying cause that may be there. And it tends to be recurrent. Okay? With abruptio placenta, it is painful bleeding. And it's often attributed to a cause. Maybe it could be hypertension in pregnancy. It could be a preeclampsia. It could be trauma. And it tends to be continuous bleeding. Then the bleeding in placenta previa is often revealed all the time. Then in abruptio placenta, it may either be revealed or it may be concealed or it may be a mixture of both. In placenta previa, the color of the blood is bright red. In abruptio placenta, it is dark colored. In placenta previa, the bleeding is proportionate to the visible blood loss, unless maybe if the patient has anemia, But in abruptio placenta, the visible blood that you may see may actually be out of proportion, especially in the concealed or the mixed varieties of the cases. In placenta previa, you may not have features of preeclampsia, but in abruptio placenta, in 1/3 of the cases, you will have preeclampsia. Then when you come to the examination of the abdomen, the symphysiofundal height will be proportional to the gestational age. There may be a disproportionately enlarged uterus due to a concealed type of a placenta abruption. Then in placenta previa, the uterus is soft and relaxed. On the other hand, in abruptio placenta, it is tense, tender, and rigid. Okay? Then you may get malpresentations and a high floating head. You may not see this in abruptio placenta because the head is usually going to engage. Then the fetal heart sounds are usually present in placenta previa. They are usually absent, especially in the concealed type of placenta abruption. Then when you do an ultrasound, in placenta previa, the placenta is obviously in the lower segment, and then in placenta abruption, it's in the upper segment. Then when you perform a vaginal examination, the placenta can be felt on the lower segment, and then in abruptio placenta, the placenta is normally not felt on the lower segment. And of course, some blood clots can be confused as a placenta. So know these differences between placenta abruption and placenta previa, not just for the sake of your exam, but for the sake of a patient's life. Now, last but not least is the management of the condition, because it's a very, very important aspect. So remember that all cases that come in of APH, even if the bleeding is slight, even if the woman said, it was just a few drops that were there and nothing significant, then, or absent even by the time this patient reaches the hospital, you should actually treat this as a placenta previa until you prove otherwise. And because, like I told you, the calm before the storm, there's usually a warning, bleeding, and then there's some quiet, and then you get this torrential bleeding that may be there that may actually tip this woman into shock, and then she may actually pass away. And the management largely depends on the gestational age, whether this person is at term or preterm, the severity of the APH, whether it's mild bleeding or major bleeding, and the type of placenta previa, if it's a minor degree or a major degree. Then the management components are going to be split into 3 things. So there's what is known as initial management, because this is considered as one of the emergencies, one of the obstetric emergencies. There's expected management for those patients that haven't yet reached term, and they're not in any jeopardy, any maternal jeopardy, any fetal jeopardy. Then you may perform expected management or definitive management. Now, with the initial management, you obviously want to admit the patient, inform your senior doctors of this patient that has APH that's on the ward, and please, on the file of the patient, indicate that this patient has APH and no one should perform vaginal examination. So you could write that in red actually on the patient file. Then assess the amount of blood that has been lost. So look at your general condition. You check if there's any pallor, if you check the pulse rate, you check the blood pressure. You want to gain venous access and with 2 large bore cannulae, and send blood for cross-match, send blood for blood grouping. You could order for 6 units, and you could do also a full blood count and a clotting profile. Then as you're waiting for blood, you can start to run some normal saline as you wait for blood from the blood bank. And then, of course, start to examine this woman. So gently palpate the abdomen to ascertain that there is no uterine tenderness that may be present. And please also confirm that there's a fetal heart tones or fetal heart rate. You can actually count the fetal heart rate and determine whether the fetus is actually in fetal distress. Then inspect the vulva. And remember, do not perform a pelvic vaginal examination, because you may exacerbate the bleeding. Only do this if you're a senior doctor and you're in theater and you're prepared for any bleeding that may occur. But if you're a junior doctor and you're on the wards and you get a case of APH, please avoid performing a vaginal examination until you ascertain that this woman doesn't have a placenta previa. Then, of course, confirm the diagnosis by your history, your physical examination, and your sonographic findings. Then, for expected management, when do we actually consider expected management? If we have a hospital where blood is always available 24/7, if we have a hospital where C-section facilities are always present 24/7, we can consider performing expected management. If the maternal's health status is actually good, if they have an HB that's greater than 10, or a hematocrit that is greater than 30, then we could perform expected management. If the duration of pregnancy is before term, so it's less than 37 completed weeks, if there is no active vaginal bleeding, and if the fetal well-being is actually reassured by the ultrasound. So what do we actually do for expected management? So bed rest. You could actually give them some bathroom privileges, but bed rest for these patients. People tend to actually underestimate the power of bed rest. So please sleep. So offer this woman some bed rest, even some pelvic rest. Tell her to avoid any sexual intercourse during that period. Of course, they would avoid any sexual intercourse. I mean, they'll be admitted in the hospital, unless if I don't even want to think about that. Then some investigations that you would want to do, you order a full blood count, you blood grouping, you would also check the urine for any proteins. Then of course you should periodically inspect the vulval pads and also the fetus with ultrasounds every 2 to 3 weeks, depending on how severe the woman may be. You may offer some supplements that may be there. If there is any blood loss, or if this patient is actually anemic, then you would also want to transfuse this patient. And if this patient actually goes into labor, you can actually avoid labor by giving tocolytics, magnesium sulfate, but please consult with your seniors before actually instituting this. Then there are some times where some doctors have tried to use cervical circlage to reduce the bleeding and to prolong the pregnancy, but usually this is not quite helpful. Then remember that anyone that comes in with a bleeding episode and you actually check the blood group and they are rhesus negative, so they are unsensitized, so you want to give them ROGAM, which is the anti-D antibodies, the RH, the rhesus immunoglobulins. The reason why you want to give them this is you want to prevent a condition that's known as erythroblastosis fetalis, where you'll have an RH negative mother carrying an RH positive baby, and then she starts producing these antibodies, and then they cross over to the child and start hemolyzing the red blood cells and causing havoc in the child. So you want to avoid this by preventing sensitization of the mother. Then the expected treatment, you could actually carry it on until the child reaches 37 weeks of pregnancy. And at any stage, if there's any maternal compromise or fetal compromise, please aim to deliver the baby. Then, of course, if the person has passed 26 to 34 weeks, you can actually give some steroids to enhance the lung development and actually reduce the chances of distress when the child is born. So you may give dexamethasone 6 milligrams as an intramuscular injection every 12 hours for 4 doses. And this is not really the drug of choice. The drug of choice is actually betamethasone, but locally we use a lot of dexamethasone. Then some patients could actually be managed at home, and this is for very, very rare cases. In cases where the patient actually lives very close to the hospital, probably in the hospital compound, or if this woman has a 24-hour transportation that is available at any time, and if the bed rest is reassured, and if the patient is actually well motivated and understands the risks of her condition, and the caregivers also understand the risk of their condition. So if they tick all these boxes, then you might as well treat them at home, because you sometimes don't want to keep patients in the hospital because they may pick up other things. Then sometimes you may decide to deliver preterm. So for example, if there's any recurrence of breast hemorrhage or if the bleeding keeps on going, then you want to deliver. If the fetus is dead, you want to deliver. If there's any congenital malformation that you see on the investigations, you generally want to deliver. Then with the definitive management, obviously it's delivery. The indications is if this bleeding is occurring at or even after 37 weeks of completed pregnancy. Then if the patient is labor, please deliver. If the patient is in an exsanguated state on admission, please aim to deliver. If the bleeding is continuing and of moderate degree, please deliver. And if the baby is dead or any congenital deformities, please deliver. Now, the modes of delivery largely depend on the type of placenta previa that you have. So if you have, like, for example, a type 1 and a type 2 anterior, those can be delivered vaginally. Okay, if with some experience, you can deliver those vaginally. But with a type 2 posterior, a type 3 and a type 4, those actually require cesarean section delivery. So for all women that have this sonographic evidence of placenta previa, where the edge is within 2 centimeters of the os, you want to deliver via C-section. So it is indicated if you have a posterior type of placenta previa or it is a very thick. And of course, this should be done by a senior obstetrician because of the experience that I've been talking about. Then with vaginal delivery, you may consider this when it's about 2 or 3 centimeters clear away from the internal cervical os, where you can determine this by ultrasound. then of course vaginal examination should be done. And this is the only time when you actually do a vaginal examination with a double setup. So you arrange in theater, you prepare a cesarean section set such that if anything goes on, then you can actually take this patient for C-section. So you want to examine this woman in theater. So the patient is taken to theater and they're prepared for a C-section. Then what you're going to be doing is you insert a speculum and you examine for any local causes of bleeding, and a cesarean section is done. Otherwise, you also palpate the fornices and determine if the placenta is covering the entire os. You may sometimes even be able to see it when you insert the speculum. And of course, this is done only on these rare occasions where the ultrasound is inconclusive and you can't really do an MRI. Then you may go for this double setup. So there are some contraindications for vaginal examination. So if the patient is in an accentuated state, do not perform one. If you have a major degree placenta previa that's confirmed by an ultrasound, please do not do a vaginal examination. If there is any malpresentation, an elderly prime gravida, a pregnancy with a history of a C-section, or even a contracted pelvis, then do not perform a vaginal examination. And some precautions that you may actually do or carry out when you're doing a vaginal delivery. Remember that all possible steps should be taken to restore the blood volume. So you want to transfuse blood, so order for blood. Then you may give methadone 0.2 milligrams IV if this woman is not hypertensive. If they're hypertensive, avoid methadone, give oxytocin 10 international units IM on the thigh with delivery of the anterior shoulder to actually prevent PPH. And the reason why we're giving this oxytocin, it helps with contraction of the uterus. Then you also want to, so this is pretty much active management of the third stage of labor. Then you also want to properly examine the cervix after the delivery to detect any evidence of any tears that may be there. And of course, the baby's blood levels should also be checked. And if necessary, they should also arrange for a transfusion. There are some special considerations that I want you to take into note or take into play before I show you the management algorithm. So if there is heavy APH, this is actually an emergency and you should do this in theater. So you could actually conduct a digital examination and palpate for any bogginess that you may feel in the vaginal fornices. And of course, doing that double setup if for the cesarean section, if the gestational age is actually greater than 28 weeks, and if they have complete placenta previa, then you can actually, or if they have placenta previa, then you may actually consider induction. If there is minimal or moderate APH and they have preterm or they are preterm before 37 weeks, then you may or actually admit them to the antenatal wards. You may keep them matched. You gain some IV access with a 2 large bore cannulae and do these obstetric ultrasounds, give them the steroids, the same dosage that I talked about. And then if they are stable, then you may consider delivering them 24 hours after. This is supposed to be after, not after the second dose of steroids. Then, of course, if there is no heavy bleeding, then all we just simply do is wait. We may perform an elective cesarean section at about 37 weeks of gestation. If there is no APH and the placenta previa is actually routinely discovered on ultrasound, then we also just want to admit them at antenatal after 28 weeks and actually treat them as we have treated these ones above, depending on whatever they have. So here's the management algorithm. So take your time, increase the, what do you call that thing for the quality again? Increase the quality on the video. Sorry, I lost my train of thought. Increase the quality of the video to see this management algorithm. If you still can't see it, drop a comment in the comment box below and I will send you the PowerPoint presentation. So how do we prevent morbidity and mortality of placenta previa? So remember, we want to perform adequate antenatal care to improve the health status of the mother and correct the anemia, because this woman will be able to at least sustain a significant amount of blood loss before she becomes asymptomatic and it becomes dangerous to her life. So you want to get her HB as high as possible. Then, of course, an antenatal diagnosis of a low-lying placenta with a routine ultrasound at 20 weeks can actually be repeated at 34 weeks to confirm the diagnosis. And we shouldn't ignore any warning hemorrhage. So if a mother comes in to hospital and she says she complains about spotting, please do not ignore this. You may also perform color flow Doppler ultrasound, and this can actually help you detect placenta accreta. And where it's not possible, then this woman have an increased risk of placenta accreta, then we should manage them as if they have placenta accreta until proven otherwise. So some complications that may be associated when it comes to complications in obstetrics and gynecology, I love to divide them into maternal complications and fetal complications. Then I think about it like this. The complications could happen before labor, so you call those as antepartum complications, or they could happen during labor, intrapartum complications, or they could happen after labor, which is postpartum complications. So you could have shock, you could have malpresentation, which is breech presentation, transverse lie, and the lie is often unstable. You may have premature labor, which may be either spontaneous or induced. Then in the intrapartum complications, you may have early rupture of membranes, cord prolapse, which may be due to, of course, abnormal attachment of the cord. You may have slow dilatation of the cervix. You may have intrapartum hemorrhage. Then you may have an increased incidence of operative delivery or operative interference. You may have postpartum hemorrhage. Sometimes you may retain the placenta, and this actually increases the incidence of manual removal of the placenta, and this predisposes them to developing postpartum hemorrhage, and this increases the morbidity that this patient can actually undergo. And some of the cases that are going to be starting off as APH may actually progress to PPH. Now, the reason why APH, especially placenta previa, may progress to PPH is because of the following things. Remember, there is imperfect retraction of the lower uterine segment that may happen because the placenta attached there and it's no longer retracting as it normally should be. And again, a larger surface area of the placenta may lead to an atonic uterus, and this is obviously due to a pre-existing anemia. You need oxygen for the contraction to happen. So a low level of red blood cells, that means low hemoglobin, low oxygen delivery, poor contraction. Then sometimes you may have a morbidly adherent placenta, like for example, placenta accreta, increta, and percreta on the lower segments. And of course, this is going to be a serious concern because it may lead to maternal death, and it may also require a hysterectomy, like I told you. Then you may also have placenta accreta as a cause of PPH, which is of course this abnormal attachment of the placenta to the uterine wall. It's actually quite rare. It happens in one pregnancy in about 700 pregnancies, but it can complicate 5 to 15% of the cases of placenta previa, 25% with Previa, and one of them with a prior cesarean section, 60% with Previa, and 2 prior cesarean sections. And so as you can see, the more cesarean sections you get, the higher the chance of you developing placenta previa and developing placenta accreta. Some postpartum complications include sepsis, which may obviously be due to an increased operative delivery. Sometimes it may be due to the placental site that is very near to the vagina. Sometimes it may be due to anemia or a devitalized state of the patient, or even subinvolution of the uterus. Sometimes it may be due to embolism. Some neonatal complications include preterm birth, low birth weight, so they are born about 15% of the cases. Asphyxia, sometimes it may be intrauterine death. Remember that there's going to be early separation of the placenta, and there may even be compression of the placenta. The cord may actually be compressed, and this is actually going to be leading to fetal hypoxia, which is eventually going to be leading to fetal death. Then sometimes there may even be maternal hypovolemia and shock, and obviously the death may also happen due to cord accidents. Then you may also get some birth injuries because there's an increase in risk of operative delivery. You may get these congenital malformations, which are actually 3 times more common in placenta previa. Now, one important note before we end this review lecture: remember that placenta previa doesn't cause intrauterine growth restriction because the normal nutrients are still being delivered to the child. Oxygen is still being delivered to the child. It only carries a risk of massive hemorrhage, and this is what can actually cause to death. And this massive hemorrhage can happen antepartum, intrapartum, or even postpartum. And of course, the other risks such as operative hazards, infections, or even embolism that may lead to death. Thank you for taking your time to listen to this review lecture video on placenta previa. I hope it helped you understand how the condition it may be. If you like the video, please share it, subscribe to the channel. Until next time, my name is Dr. Moses Kazevu. Bye-bye.